Hi everyone, my name is Caitlin Rice. This is my video presentation for Nursing 621. My topic for the presentation is preventing prematurity in infants. I'm going to be talking about legislation that was just passed in 2018 and a practice change that I think would be beneficial to preventing prematurity. The bill that I chose for my presentation is the Preemie Reauthorization Act of 2018. The bill is also known as the Prematurity Research Expansion and Education for Mothers Who Deliver Infants Early Act. The original bill was formed and signed by Congress in 2006. It was amended in 2013 and then again in 2018. The original purpose of the bill was to expand research and develop a goal of reducing prematurity in the United States. It authorizes the Center for Disease Control and Prevention to perform research and data tracking that has a focus on environmental factors, clinical, biological, and genetic. It also authorizes the Secretary of Health and Human Services to educate providers and also the public on the importance of risk factors related to prematurity. It also has a aim of educating the public about the importance of preconception care and prenatal care, and educating families about what to expect when infants are admitted to the NICU. After the original signing of the bill in 2006, prematurity rates hit an historic low in the United States in 2014. However, they have been increasing, and the reauthorization of the bill in 2018 showed a sign of recommitment to reducing prematurity in the United States. The key provisions of the Reauthorization Act in 2018 included a renewal of the CDC's aim of promoting research and data tracking in the United States, reauthorization of the Health Resources and Services Administration's activities aimed at promoting healthy pregnancies and preventing preterm labor, extension of the Committee on Infant Mortality and updates to the committee's aim of examining severe maternal morbidity, and an establishment of an entity in the Department of Health and Human Services to coordinate all federal activities and programs related to preterm birth, infant mortality, and other adverse birth outcomes. This slide reviews the current state of prematurity in the United States. Prematurity is defined as being born prior to 37 weeks gestation. The graph on the slide is from 2017, and it shows that the preterm birth rate in the United States was 9.9%, which gave the United States a letter grade of C amongst other countries worldwide. From 2007 to 2014, the U.S. had a decrease in prematurity birth rates, which was related to less teens and young women giving birth. Since 2014, preterm birth rates have been increasing, and in 2017, it was found that 17% of infant deaths were related to being born prematurely and low birth weight. And in 2018, 1 in 10 babies were born prematurely. There's also been found that there is a great disparity among ethnicity and race related to being born prematurely. Research found that non-Hispanic Black women give birth to preterm infants 50% more than white women. So we are definitely at a state in the U.S. where we need to make some changes and improve situations for women so that we can have healthier infants and then less impact on the healthcare system. This slide shows a map of the United States, and it shows the preterm birth rates in letter grade by state. You can see by looking at the map that the only state that got a letter grade A for preterm birth rates was Vermont, which was 8.1% or less. The rest of the country is a mix from letter grade B to F, with the worst being Louisiana, Mississippi, Alabama, and West Virginia with a letter grade F and a percentage of 11.5 or higher. You can tell by looking at the map that the United States has a lot of work to do in preventing preterm deliveries. I think this bill is going to serve a great function of determining the causative factors of prematurity and ways that we can prevent it, whether it be education, access to health care, or preventative care for women at all ages. So I think this bill will definitely be beneficial in improving the overall health of the United States. This slide reviews some of the risk factors associated with prematurity. The CDC reported some of the risk factors, including tobacco use, a history of premature birth, pregnancy with multiples, including twins and triplets, which is much more common nowadays due to the increased use of in vitro fertilization, infections involving the amniotic fluid and lower genital tract, chronic conditions including high blood pressure, obesity, and diabetes, being underweight or overweight with a high BMI, stressful life events, multiple miscarriages, or stress or trauma during pregnancy. Premature infants often experience both short-term and long-term complications related to being born early. This slide reviews some of the short-term complications associated with prematurity. Some of the issues can be breathing problems, where the infant has low surfactant production, and respiratory distress syndrome. Many times the infants have to be on oxygen and respiratory support anywhere from days to weeks. Heart problems can be found in infants with patent ducts and heart murmurs. Premature infants are at increased risk of brain bleeds. They are also unable to maintain and regulate their temperature, so they have to stay in isolettes for many weeks before they are able to regulate their own metabolism and body temperature. Gastrointestinal issues are very common, requiring feeding tubes, and an infant is unable to eat on their own in the beginning. Blood issues include being jaundiced, requiring phototherapy, and also becoming anemic, which may lead to blood transfusions. Many times, premature infants also have poor immune systems, which makes them much more vulnerable for illnesses and long-term allergies. Long-term health complications associated with prematurity include cerebral palsy, learning disabilities, vision and hearing problems, behavioral and psychological problems that will follow infants into childhood and adulthood, dental problems, and also chronic health issues. The economic and social impact of prematurity on society is great. In 2007, the Institute of Medicine determined that prematurity in the United States costs an annual $26.6 billion. These costs are associated with $16.9 billion in medical and healthcare costs related to the infant, $1.9 billion in labor and delivery costs for the mother, and $611 million for early intervention services. These services include programs from birth to 3 that help children with disabilities and developmental delays related to prematurity. They help children learn physical, thinking, communicating, self-help, and social skills that are normally developed by the age of 3. $1.1 billion is also allocated for special education services in homes, schools, and hospitals. It's been found that 1 in 3 premature children require special education services. The Institute of Medicine determined that these services cost $2,200 per child per year. Prematurity may long-term health conditions that prevent or limit individuals from working. If individuals are unable to work, the Supplemental Security Income Program pays benefits to disabled adults and children who have limited income and resources. My proposed practice change is the development of a risk assessment tool that will include a standardized set of questions regarding the patient's current health status and personal and family history. This tool will determine if the patient is at a higher risk for premature delivery. Using the Precision Public Health Model, women at risk would be further evaluated for treatment options, and high-risk women would be referred to a preterm birth clinic, where they would be frequently monitored and educated on potential risks and treatment options. The clinic would provide APRNs who specialize in midwifery or women's health as providers and educators. As educators, women could provide women and their families with treatment options, risk factors, and ways to prevent preterm birth. One option for the risk assessment tool is included on my slide. The risk factor would be a history of preterm birth. Different treatment options would include frequent cervical monitoring via ultrasound throughout the pregnancy to determine if the cervix is opening or shortening, where a cerclage could be placed. Another risk factor would be a vaginal infection. If this was the case, the woman could be provided with treatment options including antibiotics and also viral suppression. The data and research obtained from the Preemie Reauthorization Act of 2018 could be used to create a proposed risk assessment tool that could be implemented to prevent preterm delivery and provide women with education and ways to prevent preterm labor. My proposed practice change of the development of a risk assessment tool is based on the concept of precision public health. Through this concept, data collection through the program can be used to identify at-risk populations based on ethnicity, social and environmental determinants, including health history. Through precision public health, women who are identified in the primary population screening as being at risk are further evaluated using the precision screening. The precision screening is used to target treatment and prevention strategies to those women who are most likely to benefit. Those who are unlikely to benefit will also be identified, which will reduce unnecessary interventions and make optimal use of resources. Precision public health has been proven successful in preventing preterm birth in a statewide initiative in the state of Western Australia called the Whole 9 Months. Expecting women are screened for risk factors for prematurity, and high-risk patients are referred to a preterm birth specialized clinic. A statewide outreach program was also developed to ensure doctors, nurses, midwives were all educated and trained. Women and families were educated through print and social media. After 12 months of initiation, the statewide preterm birth rate was reduced by 7.6%, and 200 preterm births were prevented, in addition to 40 births before 32 weeks gestation. The Preemie Reauthorization Act of 2018 currently has a budget of $2 million per fiscal year from 2019 to 2023. The Congressional Budget Office estimates that it would cost about $9 million for the functionality of the program over that period. That leaves about $1 million available for grants and research. It's my thought that the risk assessment tool and preterm labor prevention initiative could be funded by that extra $1 million available. The program would be created under the Preemie Act Committee. Due to the large amount of data and research that the committee is already receiving, they could appropriately create this tool and initiative and then establish it in different organizations and clinics who are willing to participate. Any organization that was willing to participate would receive a grant out of that $1 million in order to start this initiative, with the understanding that any data, reports, or facts that they got from this program would be reported back to the committee in order to further development. One other cost that could be associated with starting this program in a clinic would be the hiring of an APRN who specializes in women's health or midwifery. This cost and salary should be taken into account for the program. The current salary for an APRN in the state of Connecticut is $115,370. Another cost that would be required would be the education and promotion of the initiative. One option would be a website. For a full functioning high-end website, the cost would be about $30,000 to create the website and maintain it for the year. And then another option would be to create a social media site where the public could observe the initiative and research it, and anyone who is interested could learn about the program. The cost to maintain a social media site and create it for 1 year would be about $400 to $700. All other costs associated with the program wouldn't be much because it's already functioning in an existing facility. It would just be the grant from the government that would initiate the program and provide the education for all the staff who are involved, including nurses, doctors, midwives, and any technicians. Most of these clinics already have an ultrasound technician that's employed, but if for some reason they did not, it would be required in order to measure cervix and do ultrasounds. The normal salary in the state of Connecticut for an ultrasound technician is approximately $80,000. so this could also be a cost associated with the program. This would be the budget for the program, and the majority of that would be supplied by the grant from the PREME Act. The only extra cost would be the hiring of the APRN if it was not already provided. The benefits of this practice change and initiative would be great under the PREME Reauthorization Act of 2018. The initiative would reduce prematurity rates and NICU admissions, which will reduce healthcare costs for the whole country. It reduces the cost of supportive services and developmental needs of children, including the Birth to 3 program and also special education programs. It reduces the emotional and physical stress placed on women and their families when they have a premature child who requires hospitalization and also developmental needs. It will reduce racial disparities among women and premature birth rates, no matter their educational status or socioeconomic status. This research and program would promote access to women's health care no matter your stage in life and no matter where you come from or where you live. And this initiative would also promote the use of APRNs to educate and provide care to women. It would allow nurses to work within their full scope of practice and would also promote interdisciplinary teamwork among nurses, OBGYN practitioners, and midwives.